they do not want to take, dose of Decadron is 0.8 milligrams per kilogram, which for a 3-year-old is about, feels like about this much. And they're already gagging on everything you give them. We take the IV preparation of Decadron. You can get the same amount in about a cc or less. And we mix it with just a little syrup or jelly or something like that. And they break down, they swallow it, and it's gone, and it's golden. Works really, really well. So croup gets racemic, humidified air, not really oxygen. They usually have an oxygenation problem, unless they're completely, okay? So that's our upper airway obstruction. I'm going to check my see it later list. Okay. Hallmark sound is stridor. Don't forget that. All right. What comes next? Lower airway obstruction. What's the hallmark sound of lower airway obstruction?
Wheezing.
Wheezing. Absolutely, that's the hallmark sound. So they sound like wheezing. What is wheezing? Yeah, it's bronchospasm, bronchoconstriction. That's important. Okay. What do they look like?
Tripod.
Tripoding. That's going to be our position of comfort in this one. They're going to tripod. I heard retractions, right, over here? Yes. These are our retractors. These are usually lower, although they can get bad enough you can actually see the seesaw respirations, right, where that little sternum collapses, that little backbone with every breath, paradoxical. Okay? What else do we see with them? They can be anxious. Anytime that their saturations are low, you're going to have an anxious child. One that we don't stop to think, but it's really important. When you think about lower airway obstruction, what you have is air trapping. When you're bronchospasms, you have air trapping. So what they do is they try to blow out air, because that's what they can't do. So they have a prolonged expiratory phase. Respiration should be in, out, rest. In, out, rest. In these folks, it's in, out, rest. In, out, rest. So you'll see them with a prolonged expiratory phase. That's actually a fairly early sign. Expiratory phase. I don't know what that word was supposed to be. Okay. They can also, wheezing will progress to the next hallmark sound, which isn't testable, but
Ronco.
actually it'll progress to silent chest. Like, I don't hear a thing in there. And you give them breathing treatment, all of a sudden they're wheezing so that the whole ER can hear. Yeah, we made them better because now they're moving air. But it's going to be decreased air movement, and that happens after they just can't blow anymore out. Bronchospasms either further. So what causes lower airway obstruction? Asthma. Really, that's it. There are some other things that we could talk about. There are elements of cystic fibrosis that do this and some of the other things, but the biggie is our asthmatics. So, let me make this really, really straightforward. If the problem is bronchospasms, what is the treatment?
Albuterol.
Bronchodilators, right? So albuterol, or what's our other big one? Zopanax. Right. We want to dilate the lower airway obstruction. There's not really a whole lot else other than if they're not saturating well, we're going to put them on O2. Any other big treatments we do for our asthmatics? We also give them a steroid sometimes, right? And that one just kind of depends, but that's usually prednisolone. A short burst of steroids. All right, any questions about lower airway obstruction? What comes next then? Is lung tissue disease. Did everybody get these page numbers written down for your abnormal vital signs? Yep. Yes? Going. On. Okay, so for after lower airway obstruction, we have lung tissue disease. What is our hallmark sound in lung tissue disease?
Crackles?
Yep, crackles. This one's the time for crackles. The other one that you'll hear here is grunting. What is grunting? What is it doing? Why is a child going?
Positive pressure.
Positive pressure. Whoever said that.
Travis.
Travis.
If somebody's saying something, it's Travis.
Okay.
Good job, Travis.
Hey.
Strong
It's
word.
actually PEEP. They're actually providing themselves PEEP because they have alveoli that are collapsing or filling with mucus or pus, and so they're trying to recruit more, and so they're trying to keep it open. I learned that lesson in the delivery room. I delivered a baby one time as part of my training. They left me to take care of mom and baby. It was a crazy day on the ward, and I was in there, baby's in the bassinet, laid, curled up, making this cute little sound. And I was like, that's fine, life's golden. And then the pediatrician arrived to assess the kid. He looked at me, how long has she been doing that? I'm like, isn't it cute? Yeah. We had a little discussion, a very professional, collegial discussion about what grunting was, and it's not really cute at all. And I will never forget that. Yeah. I mean, to me, just it was nothing more than transient tachypnea of the newborn, a little bit of transition problem, but the baby needed to be being stimulated and woken up, and I was just like, it's so cute. And that, and then my cat was like, how do these kids look? Sick. That's really a pretty good assessment. That's a great thing to say. They look sick. In what way, though? I mean, kind of define it for me a little bit.
Like limp and...
Yeah, they look like they've been ill for a few days, usually by the time you see them. So they usually have some decreased tone.
25 days.
They didn't usually get here in a minute. These guys got here in a minute. These guys got here in a hot minute. These guys got here in a minute. They've been dealing with this for a few days. They probably have had a fever. Not always, but probably have had a fever. They may look a little dry because their respiratory rate is up, so they're tachypnic. Why does tachypnea cause dehydration?
Blowing off all that water.
Water.
Insensible
You're
lungs.
fogging a mirror. If you and I get sick, we fog a mirror 20 times a minute. Those kids do it at 100 times a minute. You see a respiratory rate up over 100, and you're like, okay. So tachypnea, they might look a little bit dry. They're also going to have retractions. Okay. So we know what they sound like. We know what they look like. What causes lung tissue disease, or what is lung tissue disease?
Pneumonia.
Pneumonia. Yeah, it's not our only one, but it is our primary one. It's an infectious process. Let's talk about one that kind of goes in the middle, that everybody wants to place in both categories. RSV could be a lower airway obstruction, and RSV can progress to a pneumonia. So you kind of got both going on, and they're going to be treated very differently. If they're actually wheezing, we might actually give RSV a breathing treatment, but we don't give breathing treatments to RSV very often because it's not bronchospasm, it's plugging, it's mucus in the airways. It's not mucus in the alveoli yet, although it will progress. It's mucus in the lower airways. So it starts here and then may progress here. Does that make sense to everybody? Kind of falls in the middle. All right, so if it's an infectious process giving me problems breathing, what am I going to treat it with? Antibiotics. So these kiddos need the red pen to be back out. I have to do something to keep my brain straight. So they get antibiotics. What else do they get?
Like a thinner, like a Mucinex or...
Yeah, they make it a mucolytic, which is a good, that's your Mucinex kind of thing. We really want to avoid steroids in these kids, in any infectious process. Sometimes we have to, but we want to avoid it.
Fluids?
Fluids, absolutely, because they've had a febrile illness, they're a little bit dry. These folks might get fluids too, but we're probably going to do our fluids over here. Cystic fibrosis can be a lower airway, and cystic fibrosis can be a lung tissue disease. Depends on where they are in their cascade, because they kind of cascade sort of the same way. Plugging is what becomes the problem in cystic fibrosis. That's why we do all the CPT, which is perfect because these kids may get CPT.
There you go.
Or some postural drainage sometimes, not always, but sometimes. Fluids, antibiotics, mucolytics, chest therapy. What other treatments for lung tissue disease? Not a whole lot else really we can do with that. Oh, yeah, yes, of course there is. These kids need O2.
Oh, yeah.
I'm looking at that like, I'm missing something.
The obvious.
Ooh. Yes, they need O2. Now let me ask you a trick question. When do you humidify oxygen in children?
Always?
Always. This is my hero of the day right here. When do you humidify oxygen in children? Always. If I take this child here and I put them on oxygen that is not humidified, I will make them worse. I will take those little plugs and I will make them into concrete. And then good luck. Because then they're going to progress on to here. I'm going to take all that mucus down there. The kid's already dry. We just talked about that. And I'm going to not give fluids that way. And I'm going to make that mucus down there just like that. And those alveoli are going to collapse and gas exchange is going to stop and the world's going to be ugly. So when do I humidify oxygen in children?
Always.
That's not something you're going to see later today. That's just fine in soapbox. It is really, really important. You'd be surprised how quickly downhill these RSV babies go if they're not humidified. Like, I'm not talking about as soon as they leave the ER. I'm talking about 15 minutes after they go on dry O2. Sometimes it can be that fast that they go downhill. Let's talk for a minute about this nefarious thing that PALS calls as respiratory distress versus respiratory failure before we move to our fourth respiratory emergency. PALS wants you to be able to determine when a child is in respiratory distress versus when they're in respiratory failure. And Rachel will want to edit this right out of the video. They do a really poor job of telling you. Pause would be correct. He did. He's kind of a funny story. I had to intubate him, obviously. He was really sick. But he had airway surgery, so I was scared to death because you just never go in an airway where there have been airway surgeries. And there was no choice. This kid was not going to make it if we didn't. And my partner was handing me the ET tube, and I went in there, and whatever airway surgery they had done, I had to put a 7.5 in this 2-year-old. Because it was like this big around. I could have driven a truck through it. And I was like, she got out a 5 for me, and I'm like, do you have a 6? I put the 6 down. I'm like, do you have a 7? I mean, it was just huge, but he actually did pretty well. He was, if I could say, used to that. He was a chronic kid that had some other problems, but his primary problem at that point was that he was all better. So, all right. The last respiratory emergency that we're going to cover throws everybody off. Nobody thinks of this as a respiratory emergency, but it is. And we call that one the disordered control of breathing. So this one it's really not hard to treat. It's not hard to identify. You don't think respiratory when you think of it. Okay, the hallmark sound, if there is one, there's one of 2 hallmark sounds in disordered control breathing. Follow the same. Yeah. Snoring or absent.
Apnea?
Really shallow, maybe, would be better. You just don't really see a whole lot of sound with them. But if your kid is snoring, they're not doing something. So when I think of this one, the D, if you want to go back with me again, this is the brain ain't controlling the respirations right. That's the way to think of that when it's all about the brain. So that's my hallmark sound. If I have a kid who was snoring or had really, really shallow respirations, maybe not moving much air, I would think disordered controlled breathing. What do they look like? Well, they're usually somnolent, not always, but usually.
You're talking like a head injury type thing?
It usually follows seizures or sedations. My little kiddo that was over-sedated was a disordered control of breathing. In the pediatric world, we see seizures, and they're postictal for, when you're the nurse taking care for them, it feels like, I don't know, 7 or 8 years. Because they can't protect their own airway. Their Glasgow Coma scale's like 6, and you're like, intubate them, and the doctor's like, just a seizure, we'll recover in a little while. Meanwhile, back at the farm, I needed to keep breathing if it's not too much trouble, you know? But, so, when you think seizures, and then you have this really weird erratic respiratory rate, maybe it's really tachypnic and hyperpnic for a few minutes. It's just kind of everywhere. It's erratic. It's uncontrolled. They're usually somnolent because they're usually not getting enough to their brain, okay? What kinds of things cause it? Seizures and sedation. They kind of go together with grabbing this picture. So then the question is, if the problem is disordered control, how do we fix the problem?
Control.
What do you do when your children are out of control?
Control.
Time out. We control them, right? We take control. You ever walk into the middle of an ER code and everybody's going crazy and somebody just says, stop, everybody knock it off, we're going to take control. That's exactly what we're going to do here. We're going to take control. Maybe that means, we may intubate, we may just bag. Like my little boy just needed to be bagged, his heart rate needed to be bagged back up, and then we did need to hold his little head up for the next hour and a half till he could maintain his own airway. So we want to take control. So that means bag valve mount, valve mask. It could mean an advanced airway of some sort. If they're deeply unconscious, we could put in an oral airway. And then when they cough it out, you know, they woke up enough that they can breathe on their own. That's kind of how the ER pediatrician, PZM docs see it. They will let them be postical for a good long time. So sometimes it's also the treatment we gave them. So we have a kid at home who has a seizure disorder, and mom gives them a big old rectal Valium before they come. The seizure stops, and then they sleep for the next 6 days with a respiratory rate of 4, unless you're helping them or stimulating them. So we do. We want to make sure that we get an adequate rate with what we're doing to bag them. They may need some oxygen. If they're still actively seizing or having frequent seizures, we may need to take control of the brain altogether and give them an anti-seizure medication, paralyze and intubate them so that we stop the
Do you
seizures.
guys use Romazicon and reversal agents in kids?
So it's really, we would never use Romazicon in a kid with a seizure disorder, a known seizure disorder, because the Romazicon outlasts the
Right.
benzo, and then we have an actively seizing child. We do not like to give it at all. It's very contraindicated. Now, if I had a perfectly healthy child that had never had a seizure disorder that I gave too much Versed to, and I knew that, I might give Romazicon in that
I just
state.
got like the kid from the dental office.
No, see, we didn't know what he had. We didn't know what he had. We'll give Narcan. We'll give Narcan in the blind because Narcan is not going to give us a seizure threshold problem.
Right.
Romazicon is dangerous because of the seizure threshold problem. I can't stop the seizure. I can paralyze them, but they're still seizing inside if they've gotten Romazicon before. So we really, yes, blindly we'll give Narcan. Romazicon, it's got to be the perfect storm. I would rather even, in a kid that I know I gave a little too much Versed to, and I don't mean I overdosed them, I just mean they were really sensitive. I would rather bag them for a few minutes till it wears off. It's a short drug. I would rather not.
That's what Shelley and I were just talking about, our docs. Really, you can control somebody's breathing, but you can't control the
You
side effects.
and you cannot always stop the seizure. Yeah, Romazicon, when it first hit the streets, I was a medic at the time. When it first hit the streets, we thought we had found the other, Narcan, Romazicon, everybody, and we did. We have these seizing patients. We're like, oh my goodness, what are we doing here? Because everybody on the streets only overdoses on one drug, and it's never mixed, and they always are honest about what it was. Yeah. Right? Isn't that your finding?
Absolutely.
In fact, they
Very forthcoming.
probably didn't do any of it. I used to start my hair. It was slipped in their drink, yeah. I used to be really jaded when I worked at inner city ER because I would walk in, I would say, okay, look, I know that you only had 2 beers, you were minding your own business, and there were 2 dudes, so take it from there. And they're all like, how did you know? And when was the last joint you smoked? 1969. Well, that was a good one because it's still with you here in the year of our Lord, 1999, you know? I want to buy where you buy. It's unfortunate. Let me make sure there's nothing else in respiratory emergencies and then we'll move on. we'll come up and we'll actually do some respiratory emergencies. Oh, a 2-year-old who's grunting, somebody who is grunting needs immediate intervention. We talked about what that means, and we talked about what happens when you don't immediately intervene. But they need immediate intervention. And then the other person who needs immediate intervention is low saturations, despite O2. That's going to tell me I need to move quickly. The other thing about this one, which I didn't mention, it is important, is that the first thing I would do is reposition their airway. So if I had snoring, the first thing I would do would be reposition their airway and put in an oral airway. I would do those two things first before I tried to bag them, because they may actually really be able to be waking up to do that on their own. I think that covers respiratory emergencies. So just a minute, since this will be our first set of practices, we're going to go through a lower airway and upper airway, a lung tissue disease, and a disordered control of breathing. Somebody has to act as the team leader, and we're going to treat it like it's a code scenario. Let me tell you, kids, we don't wait till they code to make a code, because, I mean, it's true, we take a fairly healthy kid and the whole team comes and responds and we do things. Very seldom are we actually doing the compressions, and the reason is, remember, they jump off the cliff. We want to catch them while they're still up there on the cliff before they jump. So in order to pass today, when you do your scenarios, the first thing you have to do as a team leader is call for help and assign roles. So you're all going to just say that if you're the team leader, and I'm going to give you your scenario with your PAT, with your pediatric assessment triangle. So I'm going to say, from across the room, you see this and this and this. So I'm already going to give you the first phase of your assessment. And then the team leader's going to say, I would call for help and assign roles, even if the kid doesn't sound sick at that moment. Just that way that's in place. Okay, so we're going to do that, because we're going to do these kind of like we would. And then we're going to start down the airway, breathing, circulation. I'm going to give you clues as you go through that. So you're going to say, how's his airway? And I'm going to say, the airway's patent. Or I'm going to say, you hear a bunch of secretions. If I say you hear a bunch of secretions, you're going to say, I was suction this kid. And then I would say, great, your airway's patent. When you hear the word patent, you know you can move on to B, breathing. How's he breathing? And I'll describe what he's doing, what his saturations are, what his retraction level, that kind of thing. And through that, at some point then, when we get to about C or D, we don't usually have to go through the whole thing, although sometimes you have to get the history to find out what happened. At some point in that, I'm going to say, so what are you dealing with here? An upper airway, a lower airway, a lung tissue, or a disordered control of breathing? And you're going to need to tell me. And then the checkoff sheet will says, identifies respiratory failure or respiratory distress. So, they just like that one. So we'll identify respiratory failure or respiratory distress, and then we'll proceed with how we're going to treat it. Does that make sense to everybody? So there are 7 of you, and there are 6 roles in a code. So, and a lot of times we're never going to progress as far as chest compressions, especially not in the respiratory ones. So there'll be a couple folks who can sit out. I do want you to kind of go a little bit through the motions as far as whoever the monitor person is. Just lay these on the chest and turn the monitor on so we know, because the heart rate's going to be, that tells us something about our kid. Oxygen supplies are all down in the bottom drawer. Our bag masks are all out. And there's a small assortment of drugs here, but not a whole lot of them. You'll have to be creative, like, here's your breathing treatment. Here's your albuterol, or whatever. Something like that, just so that you're med nurse. So what are the roles, really quickly, in a code situation or in your code situation? Let's just review those really quick. Recorder, very important person. Meds, very important person. Compressions.
Airway.
Airway. Access, super important. And team leader. Did we say monitor? Oh, we did. Oh, access is meds. I completely.
Oh, okay.
IV and meds, and then,
Oh, okay.
see? There could be 7, we could split that up. In the pediatric ER, we actually do, because the med nurse stays in the corner with the Pyxis, and because it's not a milligram of anything. You don't get to just do this in a pediatric row. You get to just a minute, let me draw that up, because it's all per kilo, right? You guys are all familiar with the Broslo tape and how that works?
Just review that.
Okay.
Sorry.
No, don't be sorry. That's what we're here for today. I may have to go get one from the other room because I know that we have one. Just not sure where it went today. Do you know where our Brussels tape is?
I have no idea.
Okay.
It's not in that
It's
drawer,
basically that are in colors. And when I lay it next to my child, it tells me how much they weigh. So I measured, there's an end of it that's got a red arrow that says measured from here. You lay that at their head,
Okay.
you flip it out,
Uh-huh.
and where these little feet are, he's yellow. And everything on the yellow section then of that card tells me his doses. So it gives me his weight, it tells me his dose. It tells me what size ET tube I need. It tells me what size NG tube I need, what size Foley I need. It tells me everything on this little card. You need bifocals from God to see it, but it's all there. And the most important things are the drugs, and they're listed there by weight. It is important that you measure from this end. People say to remember that by saying red to the head. I don't really care whether you measure from the feet or the head as long as you measure from the red end. Because if you measure from the opposite end, then your little bitty short kid is going to weigh 40 kilos. And your long, tall teenager is going to weigh 3 kilos. And I would like to say I've never seen that done. But I can't say that and still be honest with y'all. I mean, they're coming in a full coat and they're giving baby doses to an 11-year-old because she measured gray on the tape. And so, not much chance of recovery when we're given that much Ebi to a kid who needs a lot more than that. So, that's what that is and that's how we use it. Pediatric crash cards, I don't think they are at Methodist, are actually color-coded. You do have the color-coded. So the pink drawer, if the kid measures pink, everything in the pink drawer takes care of the pink kid. Yellow drawer, purple drawer, blue drawer, life is lovely. And if you can't find it in the pink drawer, all the exact same equipment exists in the yellow drawer. It's just a little bit bigger, and the sizes overlap, so there might be one in the yellow drawer. You just move right on down, right pink drawer. So did we cover it all? I think we covered it all. Okay. All right. Let's come on up here and get started.
She wanted to say Andy.
Who's my first team leader?
I'll do it.
Okay.
Get it out.
Joe, could I ask you to go find the instructor? Do you have your instructor manual?
I have it, yes.
This is the pages that mine is missing. Remember that we've had? That's right. My instructor manual is missing the pages. I forget every time until I go to open it.
And I've just forgotten everything she said, so. It's gonna be awesome.
Think that through.
I had time.
His life is at stake. All right. You have. Who's my go firster?
I will.
Okay. You have a 10-year-old.
Oh, verse 50.
You have a 10-year-old girl brought in by first responders from her home after her mother called 911 saying her daughter was having difficulty breathing. As you approach her, you notice that she's anxious and moderate distress and sitting upright. She has increased work of breathing with retractions present, and she is pale with a capillary refill of 2 seconds.
So,
Where would you like to start?
I'm gonna start with getting help.
Yes, you called for help. Your team is here.
And assigning roles.
Perfect. I love it. Okay. What's
Okay.
next?
So everybody has a role.
Everybody
Okay.
has their role. So somebody needs to be up here by the monitor, and you're gonna be the airway person. You're gonna do compression. You can record. You're gonna do meds. Okay. So now that they have their roles, you wouldn't have to retell them. She would go ahead and start putting her on the
And if I
monitor.
already did my AFU and I
Well, that-
walked in the room and then.
You did your across the room. Those were the 3 things I just gave you. So now you would start with the first person who goes. By the way, you guys get interrupted 10,000 times because that's how I teach how I want it done.
Yeah.
So,
Yeah.
so you would start there with A.
Okay. A, how is her airway?
Her airway is patent.
Okay, how is her breathing?
Okay, she has moderate suprasternal and intercostal retractions. She has a prolonged expiratory phase. She is wheezing in the lower lobes. Her respiratory rate is 40, and she is satting 86% on room air.
86. you said?
86.
Okay, I'm gonna go ahead and put on some humidified oxygen.
Oh, I love this person. She's doing a fantastic job. There's some humidified oxygen.
And I'm gonna make sure she's hooked up to our monitor,
Okay.
sat probe,
There's
and
telepatches.
patches.
Telepatches.
Perfect. I should have turned this on. The monitor is on and you see,
I'm gonna see it sinus tag. Yeah, that's what I wanna see. I'm okay with sinus.
you have to put this in E243. Okay.
Science stuff?
Ask and you shall receive. It won't always be that easy.
Well,
Yes.
that's what I would expect to see.
Right. Her heart rate's 140.
Okay,
So now that was your breathing assessment and you put her on oxygen.
okay, and now I'm gonna see if there's any improvement in
Okay.
her oxygen saturation.
On her oxygenation status, she has improved to 94% on 100% non-rebreather.
Okay, I'm happy with that, so I'm gonna move on.
Humidified.
I'm gonna move on to circulation.
Okay. Her heart rate is 140. She's got pale skin, strong radial pulses and central pulses. Capillary refill is 2 seconds, and her blood pressure is 106/68.
Okay, I'm okay with that as well.
Okay.
So then I'm gonna go to disabilities.
Okay. She's able to answer you correctly, but she can only speak in 2 to 3 word sentences.
Okay. And then I'm going to expose and examine.
She's afebrile with no rashes. She's not been exposed to anything. And the other thing we do with the expose and examine on kids, which I forgot to mention, is get a weight. You cannot treat a child without a weight. She weighs 35 kilograms.
Okay. And then at this time, I'm gonna ask Mom, who brought her in, what was going on?
Okay, she's had a cough and respiratory distress that started about an hour ago.
Okay, and does she have any allergies?
She's allergic to molds and grass.
She's taking the medication.
They prescribed her one of those inhaler things, but we haven't filled it for several weeks.
She has a medical history.
She's a known asthmatic. She has a lot of trouble because we can't always keep her inhaler filled. She's had 3 ICU admissions for respiratory failure. And we have 3 smokers in the house.
Oh, perfect.
They're right off the card.
Yeah.
But we only smoke outside.
Right. And then, was,
Last oral intake. That one's the hard one. Yeah. So she last ate 3 hours ago.
and events.
She's had a cold for maybe 2 or 3 days, but the last 24 hours she's just been getting harder and harder kinds of breathing.
Okay, so I'm gonna.
So I'm going to ask you at this point, are you dealing with an upper airway obstruction, a lower airway obstruction, lung tissue disease? Okay, lung tissue or a lower airway obstruction. So how would you like to treat her?
I would like to give her neck treatment,
Okay.
nebulized albuterol.
Anything else you want to know? We'll just see how that works. to
I want to
start
see
with.
how that goes.
Any other
She has a
diagnostic?
known history of asthma, so I kind of want to see how that goes first before I start jumping in more than that. And I'm going to get a chest X-ray
Okay,
and continue to monitor.
perfect. Do we need vascular access in her at this point?
I would get IV.
Yeah, she's, what concerns you, so this is just a little bit of a teaching moment, what concerns you that makes you want to get a
ICU admission.
Yeah, 3 ICU admissions in a year, when you've got somebody who's been
That is epilepsy.
asthmatic.
Yeah.
Yeah, when you've got a kiddo who's been admitted before, and you know that she's been around smoke, and you know that she's
Got a lot
gonna,
of triggers.
she's gonna be admitted whether she gets better or not today, because we're gonna do a lot of social work and history on this little one, because she can't go home when they're smoking. But she came in satting 88 already, prolonged, kind of maximizing, so, yeah, very good. So I will ask questions at the end of your scenario, even in your testing scenario, like what other diagnostic studies would you like, and that sort of thing. It's more pertinent in other things than it is in this one. The current thought, just so that you know, for chest x-rays in asthmatics, we don't do them. I mean, if it's pretty straightforward asthmatic. Now, if she had any sort of febrile history or something like that, we would be doing it.
That's what I was wondering, because like you were saying she had a cough, cold, kind of like the
Yeah.
last couple of days, like that's.
But if she's got,
But
seasonal
I mean,
allergies, she's mold and grass. Now, if I hear something like an area of consolidation, like besides the wheezes, I hear crackles. Or when I open her up with my bronchodilators, now I hear crackles, then it's a chest x-ray. But what I'm really looking at then is, do I have lung tissue disease? Straight asthmatics, we're really trying to limit the amount of radiation we put through these kids. Parents don't understand that. They want the x-ray all the time, give me a chest x-ray. And we may need it, and with her history, she's one we may actually opt to do it. 3 ICU admissions, pretty significant. So, okay, excellent. So you see how that flowed just very easily. Here's your pediatric assessment triangle. I will give you that information as you're walking up to your child. And then you're just gonna call for help, assign roles, and say, how's my airway? And just go straight down. I keep it pretty straightforward. I don't throw curveballs, so if you have, like that one, I should have told you in breathing she was only speaking 2 to 3 word sentences, but they put it in my scenario at the bottom, which is like, because that would have told you a lot about her respiratory status, right? I just can't breathe, versus your 40-year-old with a lot of secret scream, I can't breathe! Yeah, okay. I just can't breathe. Give me medicine now. Yeah. All right, who is
I
going
can't
to?
breathe, and I'm telling everybody that I've had only 5 minutes before I can get back to normal.
Okay, I'm just gonna go next. Okay, so you have a 1-year-old. Yeah, you can use whichever mannequin you like for one.
Okay.
Brought in by first responders from her home. So they came to us, first responders, so no ALS at all, with difficulty breathing. And as you approach her, she's being held by mom. She appears lethargic and not moving much. Those are her tickles. She's tachypnic with increased work of breathing. She's making a high-pitched inspiratory stridor and only fair chest rises, notice. She's cyanotic.
Call for help and assign roles.
Perfect, I love it. Everybody's got their role, everybody's here.
You said she had striders for her airway. I'm wondering-
Remember to go ahead and ask, because there's usually more information. All you're doing, remember from across the room, all you're getting is the little bit. You
Okay.
get, sometimes you get more, sometimes you get the same amount, but, okay. So for airway, it appears patent with no obvious oral obstructions.
Okay, breathing.
She has a high-pitched faint inspiratory stridor with a respiratory rate of 64 a minute, moderate suprasternal, intercostal, and subcostal retractions. She's satting 84% on room air. She's nasal flaring with copious secretions.
She needed to be suctioned and have humidified oxygen.
Okay, you place her on humidified oxygen by mask and suction her. That improves her saturation to 95%, and then the suctioning improves it to, 95% is what we're gonna say. Okay. And her lung sounds are fairly clear. You can hear some upper airway noises transmitted, but nothing that's actually, you know how they feel like they're crackly, but they're not. Okay.
Circulation.
Her circulation, her heart rate is, she's on the monitor, and that's about her heart rate. It's 150. She's mildly cyanotic before you gave her the oxygen. That's pinking up. Her skin is warm, centrally and peripherally. She has strong central and peripheral pulses. Her capillary refill is 3 seconds, and her blood pressure is 75/43.
I think her pressure's a little bit low, so she might need some fluids.
Okay.
D.
Okay. So she's lethargic. She will withdraw and whimper to tactile stimulation. Her fontanelles are soft and flat.
Does she have a fever?
She does not. She's afebrile and she weighs 10 kilograms.
So we're gonna expose everything, take a look, make sure she's not being modeling, doesn't have any.
No, she's not.
Okay. Any other signs and symptoms?
She awoke yesterday with a fever, barking, seal-like cough that seemed to improve yesterday, but it got worse overnight. Keep going.
Okay.
Marshal
Any
through.
allergies?
She's not allergic to anything.
Past medical history?
Mom gave her Tylenol, so her medications, don't forget that one.
Okay, medication.
Medications, Tylenol was 2 hours ago from mom. Past medical history, she's had 2 ear infections, one at 10 months and one at 11 months.
Okay. Last oral intake.
She ate 8 hours ago, but the rest of the day she's refused her bottle and breakfast.
Okay, anything?
The symptoms seem to be worse at night with increased work of breathing, and now she's a little bit more lethargic. So let me ask you, are you dealing with upper airway, lower airway, lung tissue, or disordered visual brain? This is an upper airway problem. Okay. How would you like to treat her then?
It sounds kind of like a croup type of infection.
Uh-huh.
I don't know if that's going on. So we're giving her the humidified oxygen. She's going to get a steroid and the fluids for her blood pressure and her heart rate. And then
One more medicine that we want to give.
she could get the racemic epi.
Right. In fact, that's going to be our first line when we identify croup. That's an important piece of information for later today. Okay, so after the oxygen and racemic, her heart rate is now 160, her respiratory rate is 56. She is 99% and you've been able to decrease her from the mask down to a cannula, and her blood pressure is 77/48. How much fluid did you give her?
We're supposed to get like 20 milliliters per kilogram.
Okay. All right. So any labs or anything else you'd like to get?
We do CEC just can check for infection, and they can do chest X-ray, just make sure it's not anything.
Sure. So if I were going to treat this kid, good job, we're going to stop now and just do our learning moment about this. So if I were going to treat this kid, I would, if I were going to shoot an x-ray, it would be soft tissue neck. So I would want to look at the epiglottis to see if there's any swelling in the airway. Not as concerned about her lungs because this is upper airway. It could still be a foreign body that's up high, so we might be able to get it, we might be able to shoot both at the same time if she's small enough. Let's talk about normal blood pressure. We haven't talked about that, but her blood pressure is actually normal. So we wouldn't be wrong to do fluids if you thought that she was in distress and needed them, but she doesn't necessarily need fluids at that. We will go through blood pressure ad nauseum when we do shock here in a little while. So that's a normal blood pressure for a 1-year-old and a normal heart rate. The respiratory rate is high, so we've treated that just like we should have racemic, Decadron, and humidified O2. Very good, excellent. You identified it. Is she in respiratory failure or respiratory distress? Distress. Well, she was lethargic and not.
She's probably heading towards that.
Yeah. So they would tell us that this is failure because she's not getting it done. She's lethargic and not responding to anything but pain. So or loud
I guess I
verbal.
didn't hear that part.
Yeah. Disability. She's lethargic but will withdraw and whimper to pain. That's kind of a little bit unrealistic. If she was that far down, we would be seeing some other things. But just from reading the scenario, again, it's not that's not meaning that you would have done anything wrong. Because she looks that far down that she's not responsive, I'm probably starting a line on her as well. And if I'm going to poke her, I'm going to do labs. And then the other study that I really didn't talk about yet, because we talk about it a little bit more with the cardiac and with the shock, is we always want a glucose on a kid, always, because they use up their glucose stores really fast when they're sick. So there's not really a reason hers would be normal if you ask for it. So, and you can be wrong to not ask for it. Questions about that one? Very good. You want to write down the list, A through E. Then you did your sample. You guys are sampling really well. A lot of people skip that whole sample. Very good. Who's next?
I'll go.
Okay. That's not what you want. Oh, I love the fact that these are in order. I forgot that. Okay, you have a 6-month-old infant.
Oh, good.
EMS arrived with a 6-month-old infant from home. The complaint from parents was respiratory distress, and EMS just saw a baby and loaded it and came on over. They didn't want to mess with it.
Awesome.
Because it's scary. It's a little baby. It looks sick. As you approach the ER cot and you're moving him over, you see this on your pediatric assessment triangle. He is lethargic and not interacting with his environment, and his tone is decreased. He is breathing shallow, rapid respirations with grunting present. And he is pale and cyanotic. Other than that, he looks great.
And I love to take care of babies and stuff. Airway.
His airway is unobstructed but noisy with grunting present.
Oh yeah, that's right. I need my team. I help and roll.
Oh, that's right. Yeah, you're doing great. They're here. They're assigned.
Okay. All right. So breathing.
Are we putting this kid on the monitor? Okay, breathing. Shallow, rapid respirations with intercostal and subcostal retractions. Bilateral crackles. There's no stridor, no wheezing. Expiratory phase is normal in length. He is breathing 88 times a minute and satting 82% on
So
room
he
air.
needs some humidified on.
Yes, he does. How would you like to deliver that?
Mask.
Okay. That will improve him to 88%.
So bad.
Okay. Awesome. I like that.
Okay.
Perfect.
Okay, and then his circulation.
His heart rate is, okay, seriously? There we go. His heart rate's about 160. Here, take a little bit whenever it comes up here. I can't actually control the rate, so he's going to be about 160. He has pale, cyanotic. He has strong central and peripheral pulses. His capillary refill is 2 seconds, and his blood pressure is 90/60.
Okay. Okay.
All those vital signs, actually.
Okay, and then D.
He's lethargic but arouses to voice. So he's V on our ASPU.
Okay.
Okay.
And then I'll undress him and expose him and how he looked.
Okay. There are no rashes noted, no signs of trauma. His temperature is 39.2 or 102.5, depending on what you like.
Okay.
And he weighs 6 kilograms.
Okay. All right, and then signs and symptoms.
He had a sudden onset of respiratory distress after an episode of vomiting yesterday. No previous cough or cold symptoms. That's interesting.
Okay. Allergies.
He's not allergic to anything.
Okay. Medication.
He takes Reglan for reflux.
Okay. Past medical history besides reflux.
He has reflux. Other than that, he doesn't have that.
Last oral intake.
2 hours ago, but he really didn't do very good with it. He just working too hard to read.
Okay. And then
The events.
the events leading up.
Remember the kid, the tale of the two. If you don't remember, I'm forgetting. Remember the kid of the two 18-month-old, because the events is what tells you why. The events can always, not always, but lots of times shed that little bit of light that you didn't have into the scenario. So, he seemed fine till yesterday, and then he had a big old vomit during that feeding, and that was yesterday, and today he just hasn't woke up very well, and he's not breathing very well, so.
Okay. Okay. So, I would want a chest X-ray. I would think he's got lung tissue.
I like that. What is it that tells you lung tissue disease? What was that
The
hallmark
grunting.
sound? Grunting and the other hallmark sound either?
Crackles.
Crackles.
Sorry, grunting and
Okay,
crackles.
right, very good.
So I would want a chest X-ray. If he isn't better with the bagging, we would need to intubate.
Okay.
He
Do we
needs
need
a
vascular access?
line.
Yeah, he does.
Yeah, he's gonna need antibiotics and labs.
Yes. What lab am I gonna be really concerned about with a lethargic child? Even if I think it's probably respiratory.
Oh, glucose.
Yeah, we wanna know his glucose, because his lethargy could be just secondary to a low glucose, because he's been working so hard. Probably not. It's probably that we've progressed from distress to failure, right? So this is how we're kind of looking at that. All right, perfect. Next next person. Okay. All right, you have a 6-year-old male patient who had a seizure at home, and mom gave him, it lasted 10 minutes, and she wasn't able to break it, so they have rectal Valium at home. So she went ahead and gave him 7 milligrams of rectal Valium and called EMS, because she was told if I have to give the Valium, I should call the hospital, call the EMS team. And the EMS got there, the seizure had broken, and they brought him to you, and you're putting him on the cot. And as you come across the room, his pediatric assessment triangle, he is got snoring respirations. You hear his general appearance is he's flaccid, unresponsive. His work of breathing is snoring respirations with breathing slow is all you know from across the room. It's too slow. And his circulation, the skin, his capillary refill is about 3 seconds. And he's a little pale, but
A little pale. Okay. So I called for help and assigned roles.
perfect. I love it. They all came. They're all doing their thing.
Okay. Airway.
His airway is, you hear snoring.
Just okay. Snoring, but okay. Breathing.
What do you want to
is-
do about that snoring?
The
before you move on?
snoring. Open his airway.
That relieves the snoring.
Okay. Good. That was easy.
Just don't let go.
Just don't let go.
But you have an airway person that you
I
can
have an
assign that to.
There we go. Airway person.
Okay.
There you go. So now.
So now airway is patent. So you've
Good.
heard the word patent. Patent
On
means
to
move to breathing.
On to breathing.
He's breathing about 4 to 6 times a minute, pretty shallowly.
Okay.
He's setting 87% on room air. There's barely visible chest rise and very little movement when we hear
I'm
him.
saying we're going to bag him.
Okay, I like that.
Some
I use it.
humidified
I
oxygen.
love these things.
Yeah. So
That improves
helps us?
his oxygen saturation to
Perfect.
about 94%.
Awesome. We're gonna keep doing that for a while.
Okay.
And then circulation.
He has a heart rate of oh no, that's not what I
That's
asked.
not good.
What
was it? Well,
Anyway, systole. There we go.
Oh,
We We have a heart rate of 80.
80, and he's 6 years old?
He's 6 years old, and his blood pressure is 100 over 48.
Okay, that's normal, yeah. Okay, so circulation, skin is pink and all that we just.
Yeah, capillary repulse 2 seconds.
Disability, D.
He is unresponsive to all but the deepest of painful stimulus.
So we have the brain.
The brain is not.
Not.
Yeah, so,
Okay.
okay.
Because of the seizure,
Mhm.
so probably postictal at this point. Exposure,
There's nothing else revealed.
nothing else, okay.
And then he's afebrile.
He's afebrile, okay. And so right now, I would say he is just postictal because of the seizure and too much Valium from mom. So,
So am I dealing with an
Signs and
upper
symptoms.
airway obstruction, a lower airway obstruction, lung tissue disease, or disordered control of breathing?
disordered control of breathing.
Okay.
And, so signs and symptoms, we've already got that.
Anatomic clonic seizure and
Yeah.
dying.
Allergies,
He's not allergic to anything.
meds.
He has Valium at home.
Um, There you go. And if
Use your team, that's fine.
Past, what'd you say?
Past
Past,
medical
past medical.
He has a
history,
seizure disorder.
Disorder, okay. And then, L, last known well.
He ate fine this morning, last
Last
meal.
Okay.
There's a stroke nurse.
That's
right
good.
here. Last known well.
Sorry, that's
No,
good.
that's
Yeah.
perfect. You're doing great.
And then
Absolutely
E.
fine. Eventually, he had a tonic-clonic
Okay.
seizure.
So we cover really
Yeah.
all of
And
that.
so in this one, this one's pretty straightforward.
Right,
You still want to do those things because I could, not me, but the actual patient could throw a curveball. There could be
Right.
something else going on, like he hit his head today
Oh,
as
that was
well
a seizure.
in all of this.
Right, okay.
Because seizure patients also get head injuries and other
Right.
things. So you do want to go through it because you don't want to miss something. There's nothing more embarrassing to me or dangerous to the patient to when I get a seizure patient to the PICU and they're like, well, did you look at that big old boggy spot in the back of his head? Or did mom mention to you that he hit his head last night? I mean, yes, he's a seizure patient, but
Right.
those are the sorts of things we just don't want to forget. That's why we use a system.
Okay.
That's why we go right down the system. So the other really important diagnostic test we want in a seizure patient is going to be, we might, but if he's got a known seizure
Yeah.
disorder, I'm thinking something much simpler and much faster.
The chemistry.
It would be on a chemistry panel.
Blood
Yeah,
sugar.
glucose.
Okay.
You can see he's going to have a low blood glucose.
Okay.
That one's never wrong, you guys. It's just never
It's always
wrong.
the right answer.
I know. We
Okay.
overthink that one because it's
Yeah.
just so natural for us to
Okay.
do. But we don't want to forget that glucose is important for all of us. Okay, that's our respiratory emergencies, so we're gonna take just 5 quick minutes so we can get back and we will do then, shock or cardiac, I haven't decided yet, I'll work hard and decide, and then we'll go through the shock emergencies or the cardiac, and then we'll do the practices again with new people, and then see how that flows, we're gonna get that done. You guys are doing a fantastic job. If you keep going right down that ABC stuff, you guys are gonna get this. I've never heard sample or any of that, but it is in the proximal. You guys have seen him, but these guys who don't work in the ER. Lots of times it's in the proximal tibia, or if it's in the humeral head, you'll see mottling distal on the extremity. So their little foot will turn nice and purple and mottled if you're infiltrated. What can we give through an IV?
Anything.
Anything and everything that we can give through an IV. And what are the other salient? Oh, how long does an IO last? 24 hours. And what are the contraindications for putting in an IO? When can we not put an IO, or where can we not put an IO? Overlying infection,
Broken leg.
fracture in that extremity,
Ortheo, imperfecto, whatever that.
osteogenesis
There you
imperfecta, brittle bone disease, BBD, brittle bone disease, osteogenesis imperfecta.
If they had if there's any sort of orthopedic procedure, like knee replacement, I don't know why a 2-year-old would, but you never know.
Who knows? And then if they've had a previous IO in that, like a previous attempt,
Within 24 hours.
we're not going to go into that. All right, so let's talk for a minute about shock. What is the definition of shock? Shock is inadequate tissue perfusion. That clears it all up, right? We can go home now, we're done.
Oh, okay.
Yeah. I was thinking. Every cell in your body has two things it needs to carry on metabolism. What are those two things? You learned them in oxygen and
Sugar.
sugars. I heard it. Oxygen and glucose. Every cell in your body. Every knee cell, every ear cell, every lung cell, every heart cell, every kidney cell needs oxygen and glucose to carry on metabolism. If it doesn't have them, metabolism goes anaerobic. We get all those byproducts, and all these bad things happen. I don't really care what those bad things are. They're just not good, because what eventually happens is that knee cell dies, or that kidney cell dies, or that liver cell dies, because it's not got enough oxygen and glucose. If enough liver cells die, my liver dies. If enough kidney cells die, my kidney dies. If enough knee cells die, my knee dies. If enough organs in me die, then I die. That's what we're here to prevent. So that's what happens. Shock is essentially a supply and demand problem. I need oxygen and glucose in this much demand, and I have it in this much supply. So, supply and demand problem. But in order to fix it, everything I do has got to be aimed at either decreasing demand or increasing supply, because I want my little world in balance so that my liver cells don't die, so my kidney cells don't die. You guys get the... So when you think of your nursing actions in a shock patient, you just need to be thinking supply and demand. Why do we put shock patients on bed rest? It does what?
Decrease demand.
Decreases demand. Why do we give antipyretics to febrile shock patients?
Decrease demand.
Decreases demand. Why do we give them oxygen? Increases supply. Why do we put kids on maintenance fluid, D5 and quarter normal saline? Increases supply. Everything we do is aimed at increasing supply or decreasing demand. That's all there is to shock. If you can remember that, you'll be the best nurse in the world. Because that's really what it's about, is taking care of restoring homeostasis in every way, right? So, because it's 4 and it's PALS, remember everything comes in 4, so there's 4 types of shock. There's also 2 classifications of shock, and I don't want to skip this. I had a class last week where I kind of struggled a little bit to understand. We're going to categorize all shock as how severe it is based on one vital sign. It does not mean the kid is not sick without this vital sign. What is that vital sign?
Blood pressure.
Blood pressure. Because we classify it as either compensated or hypotensive. We used to call that decompensated, now we call it hypotensive. That should make it easier, because if they have a low blood pressure, they're hypotensive. I had a lot of students miss that last week, so I don't know if I didn't state it well or what, so I just really want, what vital sign would tell you about the severity of a patient in shock? Their blood pressure, because it's going to tell me whether they're compensated or hypotensive, okay? So in order for that, we need to know what normal blood pressure is in kids, right? Page 54 is going to tell us that from 0 to 12 months, we want anything above 60. Correct me if I'm wrong, right? That's what it says. If they are 1 year to 10 years, I am going to take 70, multiply it by their age in years, times 2. Age, and I add it to, I'm sorry. Add it to their age times 2. So, if I'm 6, what's the lowest normal systolic blood pressure?
82.
82. 70 plus 6 times 2, because that's their age, right? Age times 2 is 12. Added to 70, 82 would be the lowest acceptable systolic blood pressure before I would define them as being hypotensive. Is that clear to everybody? So if they're 3, what's my lowest acceptable?
76.
76. Does that make sense to everybody still? It's 70 plus.
Okay, sorry.
Yeah, that's what I said. I wrote it wrong. Just absolutely. I'm making it as clear as possible, because why not? 70 plus 2 times their age. Okay, there we go. Now that's some better algebra up there for you. Okay. Once they get to age 10, somebody tell me what 10 times 2 is?
21.
20. If I add 20 to 70, what do I get? What's a normal lowest acceptable systolic blood pressure in any adult? 90. So my kids, once they're 10, 90. I don't need any more than that. I'm just going to top out at 90. Is that really clear? That's pretty easy. You're going to need to know this to be able to determine the severity of the shock. Not the type, but the severity. All 4 types can be compensated and all 4 types can be hypotensive. Okay? Everybody
Just-
got that?
Just curious.
Uh-huh.
In the book, it actually says neonates 60,
What page are you
infants
on?
1 to 12, 54.
54. There's another one that's, I said there's a big table and a small table.
So it has like 4 levels.
Yeah.
Neonates, infants.
0 to 28, you're right. So it's 1 month. See, I said, correct me if I'm wrong, thank you very much, because I sometimes get kind of crazy when I'm talking up here. So it's 0 to 1 month is 60. 1 month to 1 year is going to be 70.
Yeah, okay.
See, I've taught this 1,000 times and I still every once in a while just, I did it for the recording. Okay, all right, so now we're going to dive into the 4 types of shock really quickly, and we're going to do the same thing sort of that we did with our airway obstructions. We're going to talk about what causes them and how to treat them, okay? First type of shock, straightforward, pretty easy, hypovolemia. There's no Hallmark sound anymore, we don't have. If I have had nausea, vomiting, and diarrhea for 6 days and my entire circulating volume is in the Omaha City sewer, I'm hypovolemic. If somebody shot at me or ran over me and my circulating volume is on the trauma room floor or on L Street, I'm hypovolemic. So that's not enough volume. When you think about your cardiovascular system, it's got 3 basic parts, right? It's got the contents, that's what we're talking about now, the blood. It's got the container, that's the vessels that hold it, right? And it's got the pump that pumps it. Guess what? 3 of our types of shock are going to come from those 3. So this is shock of the contents. I don't have enough contents. If my problem is that I don't have enough contents, what do I look like? Pale. I may be pale. That's a good one. What else?
Dry.
Dry. I'm going to look dry. What does dry look like?
Chapped lips.
I like that. Chapped lips. Sunken fontanelles. Sunken eyes. Oral mucosa. That's one that we talk about a lot in the adult world.
Or skin turgor.
Skin turgor. Yes. All right, that's kind of what I'm going to look like. What's my capillary refill going to be?
Slow.
Yeah, slow. So I'm going to have a prolonged capillary refill time. Okay. What's my heart rate going to be? Tachy. Yeah. I'm going to be tachycardic. I might also have obvious signs of bleeding. So first I might do is stop the bleeding, right? I mean, if it's going all over the trauma room floor, nobody wants to stop that later. Stop it. Okay. If my problem is that I don't have enough contents, what do I do about it?
Put in more contents.
So the treatment is volume. The treatment is first we do have to stop the leak. So if it's an actual trauma problem, then we'll have to stop the leak. That may mean surgery, that may mean other things. If it's vomiting and diarrhea, we may have to stop those losses. But we're going to start with replacing volume. So we give that IV bolus or IO bolus. What is a bolus in kids? What do we consider a bolus?
20 milliliters per kilogram.
20 milliliters per kilogram of
Isotonic.
isotonic crystalloid. Tell me what that means. Tell me what it isn't.
D5.
It's nothing with dextrose, you're right. So it's lactated ringers or normal saline. And most often we're going to be using normal saline. So we do 20 per kilo, that constitutes 1 bolus. When we do that, then we recheck. We should have a decreasing heart rate, a decreasing capillary refill, and a better blood pressure, right? How will I know if this is hypotensive shock?
If there's still
Blood pressure.
If they have a blood pressure below normal for their age. I know I'm driving that home, but I just don't want to have missed it again. It's like it seems pretty self-explanatory. Okay, if after this it's improving but it's not better, what do I do next?
Do it again.
Another one. We can actually do this We can do it more, but we typically do it up to 3 times before we move on to consider something else. Now, if I know that my losses are what's on the trauma room floor in blood, then I may want to move to blood a little bit sooner, because lactated ringers in normal saline don't carry oxygen. Okay? So I may want to move to blood. When I give blood, we give blood at 10 mils per kilo is considered sort of the same as a unit. So if you were going to give an adult 2 units, you would wind up giving 10 per kilo and 10 per kilo twice. Does that make sense to anybody? If we move on to blood or other expanders. So we're going to stop the losses, we're going to do this, and then we're going to deal with supply and demand. Do these people get oxygen?
Yes.
Yes. Do we let them get up and run around all over? No. So we're going to increase supply this way. This is an increasing supply action. This is an increasing supply. And we're going to decrease demand in every way that we can think of to bring this back into check. Questions about hypovolemic shock? Pretty straightforward, not really hard. What's the most important diagnostic criteria in my hypovolemic shock that is not trauma related, where my circulating volume is in the Omaha City Sewer?
Blood pressure?
Diagnostic study.
Oh, sorry.
Diagnostic,
H&H would be for my trauma patient. Which electrolyte?
Glucose.
Glucose! Remember, this is an increase in supply problem, right?
Yes.
We never bolus with glucose. Bolusing with glucose or dextrose, as far as like a big bolus, will only get us cerebral edema. It will not help us in other ways. It doesn't stay in the vascular system. So it doesn't replace contents. But if my glucose is low because I've been vomiting diarrhea, then I may need to replace it with some actual treatments of it, not big boluses of it. And that's why we put these kiddos on maintenance fluids when we're all done. This is the resuscitation phase and this is the maintenance phase. But we want that glucose early. Okay? So first, that's shock of the contents. So now let's do shock of the container. What do I mean when I say shock of the container? I have up here my water bottle. And I want you to picture for a minute that this is the head, heart, lungs, kidneys, okay? DeBrain ain't getting very much right now, because all of my contents are down here, okay? If I took and poured this into a smaller container, if I started in a smaller container, it may come all the way up to the right spot. Does everybody understand what I'm saying? So the container, all the contents are there. We pour it into a larger container, the contents aren't getting where they need to get anymore, right? So I've got the right amount of contents, but it's distributed in the wrong place, or distributive shock. What do these patients look like?
They're all puffy?
Your weak peripheral
Activity?
pulses.
Yeah.
What? No.
Edema.
Nope, this does not have anything to do with my pump. This has to do with my container suddenly got too big. My container, you know, we all have
They're
a
all pink
certain amount of
flush,
vasopressor that we use on our own.
like flush.
They can be flush, actually. Yes, they can be flush. What is their capillary refill like?
Very brisk.
Brisk, it's like what we call flash, it can be. They can also be cool and pale. Not all of them are going to be flush, but they can be flush or pale. They can have flash capillary refill, or it can be prolonged. So that's not very helpful, but it's important to know. What else do they look like? How's their bird to brain? They're not very good because everything's gone. They're going to be, yeah, they're going to be lethargic, right? Or decreased tickles, I guess is a better way to put it. Lethargic is such a nefarious word. What does it really mean? Every parent in the world brings you their febrile child and says they've been lethargic all day, right? As they tear apart the emergency department. I'd hate to see him when he's not lethargic, is what I always think when I see that. Right, okay, so what else? What else will they look like? What about their pulses? What are their pulses? Remember, we're gonna compare central and peripheral pulses.
Essentially, they're.
Bounding, they may actually be bounding because it's all distributed out to the periphery.
Can I have a diagnosis? That would help me a lot more.
Sepsis, septic shock. It's not always sepsis, but neurogenic shock would be the same way.
Okay, yeah.
Your vessels are not maintaining their tight enough, their tone enough to keep the blood in the central part of your body, so it's all dilated out. All of your blood vessels are dilated, and so all of the contents, all of your blood is distributed out to the periphery, which is great unless you're the brain, heart, lungs, or kidneys. They're slightly more important than fingernails and toes and stuff like that. So they can have bounding pulses. You also might find rashes in these folks, like petechial rashes or purpuric rashes, that kind of thing. So that's shock of my contents. What kinds of things cause it? This is not my, I have the same amount of volume that I had when I started. I just put it in a big container. Like if I poured this right now in a gallon container, it would be about this much, right? Never be at the top. Okay. What else? What causes it? I already gave you one.
Anaphylaxis.
I heard it back there.
Anaphylaxis.
Anaphylaxis is a distributive shock. It's an upper airway obstruction and it's a distributive shock. If you think about these anaphylactic people, they're flushed, they've got bounding pulses, they got secretions going everywhere, they're, yeah. And then we also have neurogenic shocks. Again, there's been some sort of insult to my nervous system that's causing me to dilate my vessels, all right? So, to treat distributive shock, if the problem is that my container is too big, I have two choices. And I'm going to hit it from both directions. What are those two choices?
Tighten the container.
Fill up the bigger container. So there's my fluid boluses, right? And then I heard the other one back there. Tighten the container. How do I tighten the container?
Cut off the leg.
Vasoconstrictors. So I'm going to use vasopressors
Turn it.
here.
Get rid of one problem.
I'm going to start with fluid. Again, what size are my boluses? 20 per kilo. I'm going to do that up to 3 times. Sometimes we do even a little bit or more. Think about your sepsis protocol in adults now, that's 30 per kilo. That's usually where you stop though. In kids, we're going 20, 40, 60 if you think about what we're doing. If we do 3 boluses, we're doing 60. If at 60 per kilo we're not getting anywhere, we're going to add the pressor. We may add it a little bit earlier depending on how hypotensive they are, okay? If it's caused by sepsis, what else do I need to do? Antibiotic therapy. If it's neurogenic, it's going to be vasopressors. They just keep bleeding out. And anaphylaxis, we would treat anaphylaxis the same way we would treat the anaphylaxis before. We're going to basically reverse what's causing. Do these people get O2?
Yes.
Yes. Why? Supply and demand, right? They get fluids, supply and demand. Vasopressors, isn't that supply and demand as well? We're asking it to go up and supply to brain, to heart, to lungs, okay? Just a few bonus tips in kids. If you can at all get your fluid boluses on before you start your antibiotics, you'll save yourself a world of hurt. When we give the antibiotics and the buggies, microorganisms start to die, they lyse. They give off all these bad toxins. What do those bad toxins do?
Make it vessels dilate.
They dilate vessels. So if my problem is already that my vessels are dilated, if I dilate them further, my blood pressure is going to drop even more. I'm going to be going to that gallon container and I'm not going to be perfusing my. Questions about distributive shock? What populations are at specific risk for distributive shock?
Elderly.
In the PALS world.
I was gonna say. Immunocompromised.
Immune compromised. So if my story at the triage desk started with he's been on chemotherapy for the last 3 weeks, does he stay in the waiting room or does he get a room? He gets a room. So my leukemia patients, my chemo patients, all those sorts of patients, anybody you might be post-transplant patients, that kind of thing. Because they're going to be at very high risk for developing distributive shock. So this is shock of the contents. This is shock of the container. That leads us to the pump. The pump is the third part of our vessel container, that'd be our blood vessel. So this is the cardiogenic shock, right? The pump is our heart, and we're going to do cardiogenic shock. What do these kids look like?
Weak, listless.
Weak. I like that. They're weak.
A little bit more frail.
They can be a little bit listless. They can seem a little bit more frail to us. Sometimes we don't know that they have this problem when they present to us. They're usually tired, right? If your heart decided to not provide you with enough today, you might be pretty just tired and pooped out. When I do assessments on them, I might hear different things in their heart sounds. I might hear an extra heart sound. I might hear crackles, but none of the rest of the story sounds like pneumonia. This is my little kid that looks like congestive heart failure. Yeah. Tail. Capillary refill time? Slow, yeah. Prolonged capillary refill time. They may or may not know that there's a congenital heart defect. Let me tell you the real live, real world way that we know that it's cardiogenic shock and not hypovolemic or distributive. We start to give them a bolus and they get worse. We go on the assumption that most of our kids have healthy hearts, and we start to give them a bolus. Now, we may have a little bit inclination, like maybe we hear a strange sound in their heart, or maybe their rhythm is a little funky on the monitor, or something like that. So instead of giving them 20 right away, we'll give them 5 to 10 a little slow and see how that goes. And lo and behold, the crackles get worse, or they develop crackles where they didn't have them before, and then we're like, I know what this is, and we completely change our treatment. Because we were giving them the bolus and now we want to back off a little bit. So this is sort of a diagnosis of elimination. I'm listening to mom's whole story. Nothing sounds like hypovolemia. Sometimes they have a history of poor feeding because they can't suck, swallow, and breathe because their heart's not letting them get enough oxygen if they do that. So sometimes you're kind of like, is it hypovolemia? They haven't been feeding well. But the story really doesn't fit, and the story really doesn't fit in the infective process, and the story just doesn't fit anything but the kid is really sick. You know, that's what's going to tell us. Something we don't do enough as nurses that could help us with our kids is palpate liver margins. People who have a congested vasculature, their liver margin comes down below their rib cage, and you can feel it. If you start to give a kid a bolus, and then all of a sudden you can feel their liver margin, stop giving them a bolus. Right? So, this is what they look like. What kinds of thing causes it? It can be really any heart problem. So we have all the congenital heart defects. We may have an abnormal rhythm, that sort of thing on the cardiac monitor. So this is all going to be related to the heart. How do I make my heart beat harder? But the problem is my heart right now is not beating hard enough to get to brain, to lungs, and everything, to oxygen it needs. How do I make my heart beat harder?
Dopamine.
Yeah, I'm going to use some sort of. Yeah, inotrope's a fantastic and right word because we want to do it without further taxing the heart, right? Like I can do an epi drip and sometimes I may need to, but epi makes your heart work pretty hard. If their heart's already upset, I don't really want to press it any further. Milrinone is the one we use in kids a lot, and it's a fantastic inotrope that doesn't tax the heart. Dopamine taxes it less than epi. Dobutamine taxes it even less. But we're looking for some sort of inotrope that will help us get this done. Okay. Do they get O2? Do they get fluids? No. Very little. This is, we're going to really watch their fluids. Okay. These are often brought to you where they're a ductal dependent congenital heart defect where the blood flows back and forth and the duct closes, and all of a sudden the patent ductus arteriosus closes at like 4 days. And what we do is we treat it by reopening it. we give them a prostaglandin that will reopen that duct and that will help. Lots of times their chest x-ray is important because it'll show us a big heart. Why would you have a big heart? You're 8 months old. Because you've got some sort of heart defect that's making your heart try to beat harder to perfusion. Okay. So I said there were 4 types. We have the hypovolemic, we have the distributive, we have the pump. There's also the possibility that something outside of my vascular system can come and obstruct the whole thing. We put a big old giant clamp on it from the outside. We call that, what kind of shock? You named one of the reasons, but what kind of shock do we call that? Obstructive.
Oh, whoops. I'm guessing, I have no idea.
That's what you said, isn't it? Obstructive?
Is it constrict?
Same idea.
All right.
You can constrict it, you can obstruct it. Obstructive is what it's called. What do these kids look like? If I come all of a sudden, I clamp off your aorta, or I clamp off your vena cava, or I squeeze your heart so it can't beat, what does that kid look like?
They're about to die.
In the ER world, we call that FTD. They're fixing to die. That's what we call it in the South, anyway. Yeah, they are extremely anxious if they're conscious at all. They're unconscious. They've got no blood flow. We've got to fix this. We've got to move very fast. It can be gradual, right? The tamponade can kind of happen a little at a time. So the right way to think about them is that they just look sick and it's sudden. Something came along and clamped this. You can have some that are a little bit slower, like a coarctation of the aorta or that kind of thing, but you're going to typically know that and see other signs. So, what kinds of things cause obstructive shock? Tamponade. What else?
Trauma.
Trauma can cause it. Most specifically, yeah, we can just kind of, like some have some pressure. One of the big obstructive shocks, is not a PALS thing, is your pregnant woman who's laying on their back. That's an obstructive shock. All you have to do is roll them over.
Okay.
But there's another big one.
Tension.
Yes, tension pneumothorax, that's a big one. If I'm in the ICU today, or I'm caring for the child that nobody can take to the floor because they're all full, they're limited to a ratio of 2 to 1 in the PICU. I can have 6 PICU kids on hold in the ER, but they're limited 2 to 1 in the PICU. And they're mechanically ventilated. They've got an ET tube. They're mechanically ventilated, and all of a sudden, my alarms go crazy, and I get a high pressure alarm, and I go in to check my kid, and they are trying to overbreathe the vent. Their eyes are this big around, despite what was adequate sedation 5 minutes ago. They're trying to breathe, and they can't. They've got poor chest rise, maybe only one side is rising and falling. There's just this sudden deterioration. They're bradycardic, their pulses are weak. I'm going to think I probably have attention. Anytime I've got a mechanically ventilated patient who suddenly deteriorates, we apply a mnemonic because nothing is complete in a class without 10 mnemonics. Right? I mean, can you get out of a class without a new mnemonic? I know. Dope. And we go right down this line to check our tube. What does the D stand for? Dislodgement or displacement, yes. How do I see if my tube is dislodged?
If it's moved from where it's marked.
Exactly. I told you at report that this was secured at 11 at the lip. You look at it and lo and behold, it's a 14. Well, where did it go? Or it's an 8. Where did it go? Right? I can actually look down inside. If it still looks to be, is it curled up the back of their throat, all of a sudden, that kind of thing. All right, what does the O stand for?
Obstruction.
How do I see if it's obstructed?
There's a bunch of blood coming out of it or mucus or.
Or if you bag them, you
Can't bag them? Yeah. Suction. Patch the suction catheter. If the suction catheter will go in, then the tube is not what's obstructed, right? The P stands for pneumothorax. And that's probably what my problem is. If I have a pneumothorax, my heart tones are not going to be in the right place, right? They're going to be shifted someplace. One thing, I might have tracheal deviation, although look for tracheal deviation in 18-month-old. I would love to see that. They ain't got necks. Is it in there anywhere? So that's not going to be very helpful. But jugular vein distension in your older kids, those sorts of things. One-sided chest rise and fall. Those are pneumothorax. How do we treat a pneumothorax? Chest decompression or a chest tube, right? A tension pneumothorax. second intercostal splice, midclavicular line, up and over the third rib. It's all better. This is not, let's get a chest x-ray and see if that's what we think it is. I remember we put a chest tube in an 11-year-old one time who was a spontaneous pneumothorax. And she was doing okay for about the first 3 minutes, and then her eyes got this big around. She was just crawling off the bed. We couldn't do anything. Her stats were dropping like a rock. And it was clamped and kinked wrong. So she was just getting this giant pneumo that was in there, and we were able to troubleshoot it before we actually had to needle her, but we were like dock over her ready to needle because it's like something is clearly going on. So pneumothorax, and what does the E stand for? Equipment. Is my equipment functioning correctly? It's really hard to hear your ventilator run in the helicopter. And I can remember one time carrying a gentleman along who didn't have any reason to suddenly develop a heart rate of 40, other than the fact that the ventilator was giving him, I don't know, maybe 150 cc type of volume. What is my equipment that time? Good. We're just like, because the first thing we do is we pop him off the ventilator and we bag him, and he immediately recovered. I'm like, hook him back up. Yeah, no, don't hook him back up. Go right back to that because it's working. So we troubleshoot this way to figure out what's going on. Think a lot about obstructive shock because one of the biggest problems with these pneumothoraxes is that vena cava that's coming back into the chest. It gets kinked just like a garden hose. And if we don't unkink it, how are they ever going to get anything, right? We also are squeezing the heart. So that is obstructive shock. It's something from outside the vascular system. It's not a contents problem. It's not a container problem. It's not a distribution problem. And it's not a heart problem. It's something exterior came along and constricted it, obstructed it. I don't care which one of those you like. How do I tell how severe shock is? This will be the last time I'll say it, I promise. Blood pressure. See? You guys do listen. All right. Let's come do shocks real quick. Shock scenarios. Oh, that's right. Okay.
Stand clear.
Okay. Okay. All right. Okay. Let's see who's up this time. Gotta be different people this time. Okay. Good. You guys want rock, paper, scissors for it, or no?
It's all right.
Okay. Just get it over with. Okay. Let's see. You are going to have a. What's the first thing you're going to do as a reminder? Perfect. I love it. We're getting this. I love it. You have a 5-year-old history. 5-year-old patient.
5-year-old history of what?
I'll get there someday, I promise.
Okay.
Especially at the end of the day, when you've been talking this long, you start saying things that you're like, did I really just say that? Okay, so this is a 5-year-old patient with a 3-day history of fever and diarrhea becoming increasingly lethargic over the last 2 hours. And she arrives, and when you approach the bed, you notice that she's anxious and restless. She's breathing a little faster than you think she should, just coming from you across the room, with a little bit of increased respiratory effort. Her circulation to the skin is pale, dry, with significant mottling, and a capillary refill of about 6 seconds.
Fetal, some oxygen, humidified oxygen.
Okay, let's start with A,
But let's,
just so we get
oh,
there.
we have to go through the
Yeah.
All right, airway.
Okay. She has an airway that's patent with no abnormal sounds.
Okay, great.
She is breathing about 36 times a minute with minimal intercostal retractions. She's satting 92% on room air. And you said you wanted to put her on some humidified oxygen. That will increase her to 100%. Her lungs are clear.
Circulation.
Her central pulses are fair. Her peripheral pulses are pretty weak. Your monitor person is a monitor. and her heart rate is 140, and her blood pressure is 100/80 with a capillary refill of about 5 seconds.
Heart rate could be fire, I suppose.
And then you heard me say her peripheral pulses are weak. Her central pulses are fine, but her peripheral pulses are weak.
So D.
Okay. She has poor skin turgor, her eyes are sunken, and her lips appear chapped, really dry and cracked.
Dehydrated. And then E is that expose and then examine.
Okay, there's nothing else notable other than the poor skin turgor. Her temperature is 38 and she weighs 20 kilograms. I'm sorry, 100.4. Yeah, 21 kilos.
Okay, so then, S is signs and symptoms.
She's had diarrhea for 3 days.
A is allergies.
She's got no known allergies.
M,
She takes Ritalin,
okay, and then P is, help me out.
has medical history. She has attention deficit disorder.
L is last intake.
She hasn't been able to take anything in and keep it for over 24 hours.
And then E is events.
She has a 3-day history of low-grade fever with diarrhea, noticing that she's becoming more lethargic over the last 2 hours.
Okay, so she needs IV access
Okay.
because she's
So
hypoglycemic.
ask your team to get you IV access.
IV access.
Like those calls.
I know, that was cute.
Okay.
So we're gonna give a little bolus here of 20 milliliters per kilogram.
Did you want her to run any labs when she stuck that IV in?
Sure, let's get a glucose.
Okay. Her glucose is 70,
That's not too bad.
okay?
So,
So your bolus is in.
okay, so we'll just get some vitals here first. Well, her vitals were pretty good, I guess.
I like to repeat vitals, so repeat vitals are good because let's think about 5 for a minute. What's our normal heart rate? Because we were at 140,
Right.
so she's tacky, not crack.
Okay, so.
And she's
helping
got
with
those
this-
weak peripheral pulse. So that's telling me she's not really circulating very well. Help you with what?
The formula again. Her age is 5 times.
So that would be for her blood pressure. And you were right, her blood pressure is normal.
Right, that's fine for her.
Her blood pressure was normal, but she's telling you that something's going on because those peripheral
Yeah,
pulses
it's-
are weak and she's tacky. Tacky is always gonna happen first, and those peripheral pulses, I can't say will always happen first, but they will happen. And that's why kids are different than adults. If we wait till we have the blood pressure drop, it's true that they're now hypotensive shock, but it doesn't mean that they're not in shock if they don't have. Let's do her pediatric assessment triangle. She was abnormal appearance.
Mhm.
Why was she working to breathe?
Oh, that's a good question.
How about supply and demand? Isn't her body trying to correct supply and demand? It's trying to drive in more oxygen. That's why she's breathing faster. She doesn't have enough volume.
Right.
So she's trying to draw in more oxygen by breathing deeper. Think about your septic patient that's got the big, deep hyperpnea respirations. They're trying to draw in more. Same rate. She doesn't have a respiratory problem.
Right.
She's drawing in because she's trying to regulate her supply and demand.
More oxygen.
Right, right. So she's telling you she's in shock and you did exactly the right thing. You went ahead and started a bolus. Now we want to repeat her vital signs. We should see that heart rate start to come down. We should see that capillary refill. Her capillary refill, circulation to the skin on her triangle was terrible. It was 5. So she was definitely in shock. We had all 3 legs of my triangle broken.
Okay.
So now we're going to repeat those vital signs, and she's satting 100% on her oxygen. After her first bolus, her heart rate's all the way down to 94.
Seems a little too low for her age.
Fine, that's good. And that's, you don't have that right in front
I
of
don't
you.
know.
You're doing fine. We can pretend we're your card right now.
Oh,
You
thank
consult
you.
your card, and
Can I
that's
use
the
the card
normal.
during the test?
Yes, you can.
Really?
Yes, you absolutely can.
Good.
Yes. And you can also turn to those pages that have the normals on them. That's why I'm saying right here, there's your card, and you'll say that 94 is a nice blood,
So
a nice
her heart rate is
heart rate,
normal
yeah.
and her blood pressure is okay.
Yes, and her blood pressure was 98/50.
So she's fine.
Yeah, so that's all fine. Do we want to give her another bolus or no? Her peripheral pulses are better, but they're not 100%. Her capillary refill's 3 to 4 seconds down. Okay, so we're going to give her a second bolus. And I would, just as this is an aside, not something that would be tested, I would get another glucose after we've done that because it will drop a little.
Okay.
And she was right at 70.
Okay.
When we kind of dilute her a little bit, her glucose
Sure.
may come down a little And we just wanna be with her because her primary problem is losses and not
Right.
just fluid but electrolytes. We're gonna want to keep doing the glucose, because we wanna make sure, remember, it's an oxygen and glucose supply and demand issue. So you've given her 2 boluses, let's reassess her one more time. Her heart rate remains at 98. Her respiratory rate now is down to 26. So I'm liking that a lot better. She was up over 30. We kind of corrected this, right? She's setting, we've been able to take her down to nasal cannula, she's 98%, her blood pressure is 94/50, and her peripheral pulses are much stronger, and her capillary refill is 2 to 3 seconds. So, any other labs or anything we would want to get on this kiddo? We got
Just
the
electrolytes.
electrolytes are going to be really important, absolutely. When they're all the way lethargic too, we might get a gas. Nothing that, this is more of a teaching moment, nothing that you needed to know, because we're looking for metabolic acidosis whenever we have those anion problems. We want to make sure we check that. We might want a blood culture, maybe it says we do here. I really want my kidney function is what I really want. I want my bilirubin creatinine. Very good, very good.
All right.
Now?
Sure.
Nice.
Dum dum. How can
I was gonna say,
The thing about when you answer all the questions is then I think, wow, he can handle it. Start for the most difficult one. Just kidding. I don't throw curveballs. I don't believe in it. Okay. Whoops. Okay, where did it go? It was here a second ago. All I can seem to be able to find right now is asystole, which is this, that's a completely different.
That's the supply problem.
It is a supply problem, and there's a lot of demand going on.
Yeah,
there, too. Okay. All right. This is a 4-month-old infant. Here, let's see here. Let's not forget to get your.
Maybe not.
Suffocate.
Get your team doing what you need them to do, okay? All right. So, this is a 4-month-old infant with a 24-hour history of high fever and lethargy, not feeding well. She's arriving to the ER. You notice that she does not react to the voices in the room. Her tone is decreased and she's lethargic. She has an increased rate and respiratory effort, you notice from across the room. And she's pale with significant mottling and a capillary refill of 5 seconds.
Yeah, they're my team.
Okay, your team is here and they are at their spots.
Airway,
Her airway is clear.
Peyton,
Peyton, I'm sorry. Her airway is Peyton, thank you very much.
breathing,
I start reading the card. Her respiratory rate is 55 times a minute with mild retractions, mild nasal flaring. She's satting 93% on room air, and her lungs are clear.
I put her on a little humidified oxygen just
Perfect.
to see if it helps.
It does, it increases her sat to 97%.
Circulation.
Her central pulses are fair, her peripheral pulses are pretty weak. Is she on the monitor yet? Is your monitor person slacking?
No, she's on it.
Oh, okay, perfect. Her heart rate is 192, and her blood pressure is 74/30 with a capillary refill of 5 seconds and cool, mottled hands and feet.
Well, I need to get some access for sure. When we're getting that, we can go ahead and get the blood sugar.
Okay, her blood sugar, since we're getting your access, is 185.
So, some fluids,
Okay. How much fluid would you like to give her?
20 per.
Okay, we're gonna start at 20 per kilo bolus, and you can keep going while that's starting to go in.
Okay, so exposure, or not, debility.
She responds only to loud verbal stimulus and only minimally.
Okay, so we need an exposure, see what she looks like.
Her rectal temperature is 102.2. She has no rash, and she weighs 5.1 kilos.
Well, probably do some antipyretics, but we need to get things for sinus symptoms.
Lethargy with a high fever for greater than 24 hours and some rapid breathing.
Allergies,
None known.
past medical history,
She was a term newborn, healthy until recently.
skipped over medications. Like
She doesn't have any medications. That's okay.
Getting Tylenol or ibuprofen or anything like that.
Mom did not give me Tylenol or ibuprofen. Why would we do that?
Why would be sick when they get to the ER?
We want you to know that she's sick, right? Okay.
Last little injury.
She had some formula earlier today, she has not been feeding well.
So then if it's,
It just really this high fever with increasing lethargy and increased work of breathing.
okay, so at this point, like, is my, what are my vitals now after?
Okay, your first bolus is in, and your peripheral pulses remain weak, capillary refill still about 4 seconds. Your blood pressure is still 74 over 30, and her respiratory rate is 50. Her heart rate has come down to 160 though.
Probably try that.
What did I say that led you to bagger? I'm sorry. What did I?
She's working that hard to breathe, and she's breathing that fast.
50? She's 4 months old.
Oh, 4 months old, okay, sorry. Yeah, that makes sense.
I think the oxygen, I mean, her oxygen saturation's improved with the oxygen.
Second bowl.
Yeah, I think that's where I would be focused. We still have weak peripheral pulses and prolonged capillary refill. So I would be focusing on
Okay,
fluids.
so, yeah.
What kind of shock do you think you have here?
Distributed. Nothing wrong with that. We get a little help from
I was
people
just
in the
about to
room.
ask. That's funny. I was just about to ask. So what kind of shock do you think you're experiencing? So what are our hallmark treatments? We have a shock of the container, right?
Right.
So we're starting to fill the container, which you recognize. We're on our second bolus now. So what else do we need to get going with it?
Well,
What kind
Yes.
of distributive shock do you think?
honestly, she's had this fever. She's septic,
Yeah,
maybe.
That's what I would be focusing on. Is
But
sepsis.
honestly, if it's a baby and she's had this high fever, I'm thinking she might just be that dry. She burned through it all. She hasn't been eating well.
She might be. She hasn't been eating well, but another question that we ask that doesn't come up in the sample that comes up in ENPC is diet and diapers. When was the last time she had urine output? Because if she's making urine, then we can be,
Right.
we can learn a little bit more. But the fever makes me think, if she was less than 90 days old, if she was 3 months old, we would automatically think infant sepsis, right? She's 4 months old, so we would be, we really are thinking about sepsis. We're thinking about shock of the container. Now, she's a cool, pale shock of distributive. And remember, they come in 2 varieties, cool and pale, and flushed and bounding. So you're not wrong to think that way, but you just have to keep going. And we have to consider that I'm going to be looking for the source of infection, right? That's the big thing in fever that we don't really stress when we're talking about kids. We have to find a source. So if we're looking for a runny nose, we're looking for a throat, we want urine, we want blood cultures, we're looking for our source. And in the meantime, we're treating. So you're doing great. I would just continue. I would give her the 3rd bolus, see if that improves us anymore. Because we're bringing her heart rate down a little bit. We brought her respiratory rate down a little bit. And it's in the top range of normal now. She's at 50, so I'm okay with that. And then if I'm not getting any improved mentation showing me, then I may move to what? Vasopressors. Because that's what they so that's exactly what we need to do. Other labs we would want on her, I guess I just kind of named them. It's the sepsis workup. It's the urine, the blood, all that. Yeah, we would probably spinal tap. If we didn't see another clear source, we would be spinal tap. Okay.
Hi,
Hi, we're gonna be fine.
everybody's gonna pass?
We're gonna, shh. We're gonna be fine.
Can I have that roster back that I gave you?
Oh, man, you're so much work.
Did all set, well,
I'm
if
just
they want
they're
their
all here.
cards.
I know. Please. Here it is. As I say, Rachel helped me do the paperwork this morning, so I've got it scattered right now.
So I will do their cards while they're still here, so.
You have to.
Sorry to bother you.
That's all right. Okay, so you actually did it right. You may not know from that test value, and it's possible that your septic shock patient is dry anyway. We got to get the contents back in there or fill that container. So the treatment's going to be focused the same way. The only thing that would change my view of it would be if they start getting worse. And I would start thinking, that's pretty junk. But we're going to want chest x-ray, all that on this baby. Okay, excellent. Who's next? And what other one type of shock? Okay. Where did I just put that book? Right here.
I just climbed everything out. Wait a minute.
Okay, you have a 14-year-old with the heart rate might be a little bit different, I think.
Can't wait.
Well, you have one option, don't miss.
It's got a dead battery, so she's not going
She just like walks next to Chris and just like.
Sorry. This is a 14-year-old female patient with a 48-hour history of respiratory distress, with some increased work of breathing. When you walk in the room, you notice that she is mildly lethargic. She will respond to you, but she's not really interested in responding to what's going on. She's kind of sitting there. Yeah. But she's like not giving you anything, you know.
Where is her phone?
Yeah, right.
Her phone in her
Her
hand.
phone is laying on her lap,
Oh,
and texts
God.
are going off, and she is not
Oh,
picking it up.
We have a secret.
Room one.
Her breathing that you notice from across the room is labored with moderate to severe intercostal and subcostal retractions, and she is pale with significant mottling and peripheral cyanosis. Her capillary refill is 6 seconds. Other than that, she's great.
She has her phone on her lap. No, that's not good.
Okay,
I'll gather my team and assign.
perfect. Your team is here, and your roles have been assigned.
Fantastic. And move her airway.
Her airway is patent.
Fantastic. Go with breathing.
Her respiratory rate is about 30 a minute with mild retractions, some occasional grunting. She's statting 89% on room air.
89% from air with grunting. We're gonna not over the 15 liters with humidified.
And that improves her to 100%.
Fantastic. Circulation?
Her heart rate is 180.
Mm-hmm.
Her central and peripheral pulses are present but not strong. Her peripheral pulses are weak and thready. Her capillary fill is 5 seconds. She is cool and mottled with a blood pressure of 70/40.
70 over 40.
Mhm.
Fantastic. We're gonna get us a line and we're gonna start fluid bolus.
Okay. How much fluid bolus would you like to give her? Or would you like to proceed down your sample before you give her a fluid, before you decide how much fluid bolus you're going to give her?
A little bit more, but we're getting access.
Okay, we're going to work on access for you and get all those labs. Okay.
I'm gonna do the sample real quick.
Yeah.
So signs and symptoms.
She's just had, over the last 2 days, an increased work of breathing and just not feeling well. Like severe fatigue. She won't answer the phone. She hasn't looked at her Facebook or her Twitter in 2 days.
Yeah, right.
We're done in the ER. She's going right to ICU. Any allergies?
She does not have any allergies.
Medications?
She does not take any medicines.
Medical history.
She doesn't have any chronic illness. She did have a cold about 10 days ago, a pretty severe one that she seemed to be getting better from, and now she's getting worse over the last 2 days.
Last time she ate?
She really just hasn't been interested in it in the last couple days. She's eating, but just not great, you know.
What was she doing before this happened?
Mostly laying around. We thought she was getting better from that cold, but now she's getting worse. She did
Does she have a
complain.
cough?
She did have a little bit of cough, but she did complain sort of some, like, just chest pain, especially with deep breaths and stuff.
Give her something.
So, now back to that bolus. We're gonna start that? I mean, yeah, we're gonna start it, but how much are we gonna give her?
We're gonna do, let's do a slow 10 right now.
Okay, so we're gonna start at 10 cc bolus, and,
Let's see if we can get a chest x-ray,
okay,
do a 12-lead EKG.
perfect. This one we're having to dig a little bit further on, but you're digging in the right things. So your chest x-ray shows a little bit of cardiomegaly with some prominent vascular markings. She has developed some crackles since you started your bolus. And her heart rate's remaining 180. Her respiratory rate went up when you started that bolus. She's now breathing about 40 times a minute, and her saturations are coming down even with the oxygen in place. Her 12-lead EKG shows global ST elevation in all leads.
Can I ask Mom, they know any cookies?
Mom says she's perfect. She doesn't need to drive. Are you
Perfect.
kidding me? She doesn't.
I'm
She
throwing a
doesn't
flag on
drink.
that one.
Yeah.
Okay.
She got global elevation.
So what kind of shock do you think we're in here?
Cardiogenic.
Yeah, we're in cardiogenic shock. We may not land on the Y today, it just may not, but who do we call? Cardiology, absolutely. We want somebody bigger and better than me to look at this EKG, right? She's got pericarditis, endocarditis, myocarditis. She's got the perfect storm for it, right? Cold, 7 to 10 days ago, seemed to be getting better. Lethargy, why is she work and breathe? She's in congestive heart failure, so it's not a primary respiratory problem. This is a shock problem, and it's cardiogenic. And our bolus made her worse, so we stopped that. What else then will we want to do? Because her pressure is down in the 60s and 70s. And we want to get her to PICU, and we want the cardiologist to tell us, well, yeah, we can do some dobutamine or dopamine, something like that. We've got to increase that stroke volume. We've got to increase it. Okay, and you did a great job with your labs. That was the perfect one. See, I threw you the curveball. Cardiogenic is the hardest. Who's left? We've got, is everybody gone? Then we start again. So we have one more shock emergency.
Do it for the team, yes.
You, this one's short and sweet and easy. You are caring for a 6-year-old male patient that has been down in your ER for 6 hours. It's a massive snowstorm. You can't even get him to Children's. He needs to be in the PICU because he is intubated from respiratory failure. and you're holding him. Let's go through the process. You're sitting out at the desk going, oh my goodness, how do they get here if we can't get somebody out? If it just keeps flowing in.
Not even across the street.
Hey,
We'll
they
go through the walkway.
You're
Can't use the
drinking
walkway.
chocolate to try to calm you, and you just had it. And then respiratory therapy went on break, and the alarm started going off on your vent.
So I go in the room.
And from across the room, you notice that all of a sudden the sedation that was adequate a few minutes ago is no longer adequate. His eyes are floored. He's trying to overbreathe the vent. He's pulling on those restraints you have, trying to get that. His oxygen saturation is 40%. His heart rate is 40, and his blood pressure is 40. He's just 40 across the board.
Okay.
Where would you like to start?
I'd like to assemble my team and then I'd like to pop them up and then.
All right, they're all coming running. They're like, wasn't the chocolate enough? What's wrong with you? They're all here, and they're all
Airway.
His airway. She says, I can't bag him.
Okay, so we're going to see what we need to do. We need to look at the tube. Is it displaced?
Well, let's see. It was at 12 at the lip, and it is currently at 12 at the lip.
Okay, so then we're gonna go for an obstruction. We're gonna kind of suction and see if we can.
Suction catheter passes with no difficulty whatsoever, and no
And
secretions.
then the P. Does he have a pneumo?
He doesn't have any lung sounds on the right. Only the left side of his chest is moving, and he has heart tones way over on the left rib margin, way over there.
Well, shoot, we might need a needle decompress. So we're gonna prepare for that.
Okay.
And
Betadine, swap, 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 swap. Here's your 18 gauge.
We're gonna go, second intercostal space, midline line, just above the third rib. Alright, and now we're gonna
His heart
reassess.
rate is increasing. His oxygen saturation is increasing. Your respiratory therapist, or your nurse, because your respiratory therapist is on break, is like, oh, I can bag him now. And he's still pretty nervous. He's still pretty anxious.
Sure.
And everything's improving as we
So we're gonna need a bag. And
What type of shock do we have here?
supply and demand.
All shock is supply and
Oh, yeah,
demand.
yeah.
So is it obstructive shock? So this is obstructive. And the severity of his shock, compensated or hypotensive? His blood pressure is 40.
Hypertensive.
Yeah,
Yeah.
really. Okay, excellent. All right, let's move on. Do we need a break or do we want to press on to cardiac? Everybody okay with pressing on?
Sure.
I think let's take 5 minutes.